in the airways. If it's in the parenchyma, it's either an infection, autoimmunity, and malignancy. And if it's in the pleura, it's an exudative pleural effusion if it's subacute. Let me show this to you visually. And this is the question that we were grappling with, is what subacute respiratory disease process were we dealing with? And the clues were the radiographic pattern, which were, which was reticular nodular. And we then got a little bit more clues, but let me show you what I'm talking about. So we were in this world, subacute respiratory disease. And the first step was to localize, are we in the airway, bronchiectasis or bronchiolitis, or are we in the pleura with an effusion? And we had some CT findings that localized to the parenchyma. And the question becomes, are you dealing with an infection, an autoimmune disease, a malignancy, or an ILD? And in our case, we had acute inflammation, and acute inflammation prioritized infection. And so we were in the world of these infections. You'll see that so many infections can do this that it's important to stay broad. A bacterial abscess or a granulomatous bacterial infection. Every fungi under the sun, except Canada, can cause pulmonary disease. Or even every fungi over the sun, on the other side of the sun, in another galaxy, can cause subacute pulmonary disease. And there are a couple of parasites that can do it. So what clues did we have? The clues that we had yesterday were that the patient had pancytopenia. And so we were trying to marry subacute pulmonary infection with pancytopenia, and the overlap is a granulomatous infection. And the granulomatous infections that have a propensity to go to the bone marrow are Mycobacterium, tuberculosis, and histoplasmosis. You'll notice that there are a lot of granulomatous infections that don't tend to go to the bone marrow, things like visceral leishmaniasis and nocardia. And then we learned the patient had HIV. And so the exercise, what is the cause of a subacute granulomatous infection with propensity to bone marrow in a patient with HIV? And again, you're down to that list of TB and really histoplasmosis. And yesterday, it turned out to be histoplasmosis, which was a fascinating case of disseminated histo in the presence of advanced HIV. So what do you take away from yesterday's case? In the patient with shortness of breath, localize it to the airway, to the parenchyma, or to the pleura. And you can use your stethoscope and your imaging to localize to one of those two disease processes. The overlap between granulomatous pulmonary infection and bone marrow is extensive, but it prioritizes TB and histo. And recognize that patients with histoplasmosis are at risk for disseminated disease when they have HIV. And that really was the three pillars of yesterday's case. I'm not sure, Rez, if we have somebody in the chat who's volunteered to present, or somebody else has been keeping an eye on it. Oh, it looks like Gabrielle might have another case today. If I'm getting this wrong, please correct me. But that's true, Gabrielle. We would love to hear another case of yours. Please unmute yourself and say hi.
Hi, everyone. My name is Gabriel. I presented a case yesterday about isoplasmosis. I'm very excited to be here today. Actually, this is not an original case, but I encourage if you guys have one. But otherwise, I could present it, and I guess we could have fun with it. I personally like it when I discussed this case last year, so I hope you guys too.
Absolutely. Absolutely. Jump on in, my friend.
Could we start? Okay, so let's do it. This is a case of a 36-year-old male with 6 months of abdominal pain and diarrhea.
And Gabrielle, nice to meet you. My name is Reza. Thank you for volunteering to present. I look forward to discussing this case. And right away, we have two chief concerns: abdominal pain, diarrhea. What is a diagnostician to do? Do we tackle the abdominal pain? Do we tackle the diarrhea? And ultimately, how do we create these overlapping Venn diagrams? I will tell you, both of these complaints are often bystanders in medicine, meaning they're not a great clue to the final diagnosis. So I will talk about each of them. Actually, no, I'll talk about diarrhea and then give chronic abdominal pain to Robbie to talk about, and then we'll get more of the history. So when you approach the complaint of diarrhea, the major branch point in chronic diarrhea, notice how we're applying tempo of disease to each of these chief concerns. You want to ask the question, are we dealing with an inflammatory cause or a non-inflammatory cause? How do we make progress? In the HPI, we ask, is the patient having fevers that would point to inflammatory cause? Is the patient having hematochezia or bloody diarrhea? Again, inflammatory. Is there pus coming out of the rectum? Again, inflammatory. We're going to get this data from Gabriel, but let's say if we are dealing with inflammatory, I think about inflammatory bowel disease, whether it be ulcerative colitis or Crohn's disease, infections, not any kinds of infections, but specifically bacteria like tuberculosis, Aeromonas, viruses like CMV, HSV, parasites like schistosomiasis, and Amoeba histolytica. And it sounds beautiful when you say these words. There's almost poetry to them. So inflammatory bowel disease, infections, you can think about immune checkpoint inhibitors based on the past medical history causing an immune-mediated enteritis. Radiation therapy would be another etiology. The one that I didn't mention is ischemia. Ischemia can lead to inflammation, but it's not associated with diarrhea. And finally, infiltrative diseases, lymphoma, adenocarcinoma. Now, if you get into the non-inflammatory diarrhea, here you can break it down based on the stool osmolar gap. If the stool osmolar gap is less than 50, you can think about hormonal abnormalities like thyrotoxicosis or neuroendocrine tumors like gastrinoma, VIPoma, and carcinoid. You can also think about microscopic colitis, villus adenoma. But if the stool osmolar gap is greater than 50, then think about functional causes, think about osmotic causes, and think about malabsorptive causes. Base rate of disease is IBS, diets like the FODMAP diet, and inflammatory bowel disease. So whatever is causing the diarrhea has to explain the abdominal pain. And here's where I pass the mic to my younger but smarter brother, Ravi.
Folks, I'm going to call him out on this. He's calling me younger and smarter, but we all know the person who smelt it, dealt it. Yes.
Robbie, one thing I want to just say today,
Yeah.
like when people say, oh, the diarrhea, it's smelly diarrhea. What diarrhea doesn't smell? The urine is dirty.
Only when you have COVID.
All right, I'm done.
Only when you have COVID does diarrhea not smell. By the way, I'll tell you that there's a new puppy in this house, and I can guarantee you the diarrhea smells, unfortunately. But we're not.
Is that real? Is that true, Robbie? It doesn't smell. It's not smelly with COVID.
No, it smells so much.
Oh, okay. I never know what kind of pearls you're dropping.
There you go. That's the quality of my pearls. Diarrhea smells. Thank you for coming. Okay, a dose of real life. Just one small dose. If you walk up to me in the emergency room and you tell me a patient has abdominal pain, I'll be like, tell me what the CT is. I don't want to hear the differential diagnosis. What's the CT? The truth is that abdominal pain is uncovered by CT in the vast majority of diagnoses. Every single thing that you can think of with 5 diagnoses is an exception, 5, show up on CT. So what's an approach to abdominal pain? Tell me what the CT is. Simple. There's no way in the modern era that you should approach it differently because you have a tool better than the stethoscope, better than the exam that tells you what the answer is. So what are the 5 diagnoses that don't show up on CT? Inferior myocardial infarction, urinary retention, zoster, an inguinal hernia. You probably should diagnose it before CT. And last but not least, pancreatitis, because you can diagnose it with lipase. 5. So if I ask you what's your approach to abdominal pain, you should be like NCT. This EKG, inferior myocardial infarction, urinary retention diagnosed by point of care ultrasound and bladder scan, zoster exam, hernia exam, lipase. What's your approach to abdominal pain? Or CT, okay? Hey. Very different when the pain is chronic. When the pain is chronic, the overwhelming odds are that it is either an atypical presentation of what should have been acute and the patient, for some reason, sought care in a delayed manner. But if the pain is truly chronic in its pathophysiology, the overwhelming odds are that it will not show up on CT. So what's your approach to chronic abdominal pain? You have to incorporate the base rate of disease and then morbidity. What are the more common causes of chronic abdominal pain? 3 of them. Irritable bowel syndrome, endometriosis, and what's called acnes, acute cutaneous nerve entrapment syndrome. 3 common causes. The truth is that there are 2 other ones that are very close and probably deserve to be considered amongst the common causes. So here we are, and with 5 again. What are those other 2? Chronic pancreatitis, which is one of the rare diagnoses that actually does show up on CT, and chronic mesenteric ischemia. What's your approach to abdominal pain? EKG, point of care ultrasound for bladder urinary retention, zoster, hernia, lipase. What's your approach to chronic abdominal pain? Irritable bowel syndrome, endometriosis, anterior cutaneous nerve entrapment syndrome, chronic pancreatitis, chronic mesenteric ischemia. But how could you be fooled? You could be fooled by an acute or subacute syndrome masquerading as chronic because the patient thought to delay care. So what did we learn in the last 5 minutes? I will pass the mic back to my dear friend Gabrielle for more information.
By the way, the chat was really exciting too. Anne-Marie mentioned a diagnosis I've never heard of.
Yeah.
Brainerd diarrhea. It sounds like brain and nerd, which are synonymous, but Anne-Marie, do you want to, I don't know if you want to unmute yourself or we can all just look at, I'm Wikipediaing it right now and I'll put it in the chat.
So full disclosure, I do not know a lot about Brainerd diarrhea, but my understanding is that there's been it's thought to perhaps be infectious, but no clear infectious etiology has been identified. But there's been like a few outbreaks of people who just like get this like chronic explosive, it like starts as acute explosive diarrhea and then will go to chronic, sometimes lasting weeks. And then it has been perhaps, I think, associated with unpasteurized milk products. But that is about all I know about Brainerd diarrhea.
That's a million times more than I know. Thank you so much. Gabrielle, if you don't mind, take us all through the HPA, all through the past medical history, and all through the physical exam, right before the lab, so we can make progress, my dear friend.
Hey,
Yes,
can I make one comment real quick? Even after CT scan, the most common cause of abdominal pain in the ER is we don't know. Multiple times a day. So, I think for everyone out there, we're stumped. Sometimes we don't see anything. So just keep that in the back of your mind. You've done everything. The CT scan's normal. That happens. And most of the time those resolve.
Wow. That's a great pair. Guys, I loved your discussion, and let me tell you that the chronic diarrhea schema on the CP solvers was one of my favorites and helped me a lot last year too. So 6 months before, the patient referred that the abdominal pain started in the lower right quadrant with radiation to the right lumbar region. That pain aggravates with movement. He also referred no variation with food intake at all. 4 months before, he started having fever and diarrhea, 4 episodes per day with mucus. No blood. He was treated with ciprofloxacin because they thought it was an infectious diarrhea, but the patient referred no improvement. He has been taking ciprofloxacin for like two months. 3 months before, he referred a development of a hard rock painful mass in the right lower quadrant abdomen. In all the course of the disease, he had lost 15 kilograms. He also referred no salt scrubbing. So in past medical history,
Could you repeat that? Would you say he had no what?
no salt craving, like
Salt?
thinking-
Salt craving?
yeah, sorry. In past medical history, he has a history of a chronic anal fissure. In meds, he has been taking ciprofloxacin for 2 months. Family history, not remarkable. Social history, he lives in San Martin. And for taking in context with you guys, San Martin is a tropical humid region in the northern east of Peru. The climate is kind of the Amazon. So, and he came to Lima because in his local hospital, they couldn't find an etiology. So in the physical exam, past medical history also, he was diagnosed with XDR TBC 10 years prior presentation, but he completed the treatment. And HIV ELISA was negative also. So temperature, he was 37 Celsius, heart rate 86, blood pressure 150/70, respiratory rate 18. And in the physical exam, general appearance, he looked very pale and skinny. Lymphatic exam, there was no cervical or inguinal adenopathy, but it was noted an axillary lymphadenopathy with suppuration. And if the abdomen exam, the most exciting part, it was noted a mass of 4 and 2 centimeters in the right lower quadrant that was painful to touch and not mobile. So is that okay with you guys, or yeah? Excellent.
All right, my dear friends. So maybe I can tackle the rest of the HPI and the medical history, and then leave the exam for Reza to reflect on. And I think what we later learned was that the center of disease, which was initially a diffuse abdominal pain and diarrhea, takes a predilection for the right lower quadrant. And then I think most times when you think right lower quadrant, you really have to think about 3 things. Is it the cecum? Is it the appendix? Or is it the ileum? And the cecum is important to think about because of the possibility of cecal diverticulitis, which is rare in the United States, but actually more common in other parts of the world. You have to think about the appendix because appendicitis is the most common cause of right lower quadrant pain in the acute setting. But the subacute time course really pins it most compatible with the ileal disease. And why the ileum? The ileum is a place that is very rich in lymphoid tissue and a common site for local disease through the lumen itself, but also a site for metastatic lymphoid disease, either lymphoma or granulomatous disease. So it really is the most immunogenic section of the gastrointestinal tract, as manifested by the frequency of ileal tuberculosis, ileal Crohn's disease, ileal sarcoidosis, et cetera. So the ileum really is the most common sort of immunogenic place of it. So what do we say, okay, there's a right lower quadrant, there's either the cecum, the appendix, or the ileum, and the subacute time course prioritizes ileal diseases. And the question is, how does the fact that a large mass develops at the site of the ileum prioritize this case? And I think what you really can do is study the ratio of how much local disease is there compared to metastatic disease. And when a mass gets so big with very little systemic signature, you probably would prioritize an infection. But when the mass is small compared to the size of metastatic burden, you prioritize a malignancy. And here the tension, as we'll see on the exam, is that there's a little bit of signal very far away from this ileal process with the lymph nodes. But I think you have to step back and say, like, okay, I'm probably dealing with either an infectious or autoimmune process because of the large development of a mass. Now that mass may be a simple, large pyogenic abscess as a result of occult perforation from Crohn's disease or inflammatory bowel disease, or maybe the primary driver. Now, what would be the primary driver of a right lower quadrant infectious mass? And that's where you probably look back at the bacterial causes, because a virus is probably not going to do this, but a bacterial cause. And here we are thinking about Mycobacterium tuberculosis again. And it's hard to ignore, as a result, the history of a multi-drug resistant tuberculosis that he's had in the past. But the one cool thing about TB is the rate of recurrence in fully treated disease is very, very low. Not zero, but low. So to summarize, we found the disease coalesced to the right lower quadrant in the subacute time course prioritized ileal disease, which is a site of granulomatous infection, granulomatous autoimmune disease, most commonly Crohn's, and granulomatous cancers like lymphoma. The more local disease you have, the more likely you are dealing with a local infectious process. And the local infectious processes are tuberculosis primarily, Whipple's disease, much less commonly causing a mass, histoplasmosis, and importantly in this part of the world, to think about Entamoeba histolytica. Now, Entamoeba is a fascinating infection that has hyperacute, subacute, and chronic versions. The most common variation we hear about is a subacute dysentery, but it actually can cause an acute necrotizing enterocolitis over the course of hours to days, and has a chronic abscess forming propensity. It's actually called an entamoeboma. What progress can we make with the other clues that we have in the background? And that's the chronic anal fissure. So anal fissures are a sequelae of constipation. This patient is having diarrhea. So the fact that you see an anal fissure combined with diarrhea should make you question the most common cause of anal fissures, which is constipation. The other thing that would clue you into a non-ordinary cause of anal fissure is the location. Most anal fissures are located in the midline, and not just anywhere, they're actually located posteriorly. So an anterior anal fissure or a lateral anal fissure is a clue for a systemic disease. And here, because of what else is going on in the GI tract and the fact that the patient's not constipated, should make you think of a systemic cause of an anal fissure. Now, what are those? The most common cause is Crohn's disease. In the world, you also have to think about tuberculosis, actinomycosis, which maps on very well to a right lower quadrant mass as well, and Entamoeba histolytica. So where are we with this data? We hear TB in the background, but it's fully treated. We are in a subacute ileal process which prioritizes tuberculosis, Whipple's disease, actinomycosis, histoplasmosis, and Entamoeba histolytica. What's most compatible with an anal fissure that is unusual? Well, most anal fissures are constipation related as a result of diarrhea. Diarrhea here makes that unusual. So where are we? We probably have to revisit tuberculosis. We have to revisit actino. We have to revisit Entamoeba histolytica, and wonder about the possibility of Crohn's disease with cancer there, not gone, but in the background for now. All right, Rez, you're up.
All right. I actually have zero to add. I will just say lymphoma is another diagnostic possibility with a mass, GI involvement, and lymphadenopathy. Gabrielle, back to you, my friend.
Wow, guys, I love it. I don't really know how you come up with those amazing ideas, really. So I will give you the labs. Hemoglobin was 7.5. Leukocytes 16,600. Oh, I don't see Travis's writing.
Travis.
Can you not see the screen?
No, it's not being updated.
Let me, I'm typing on it. Hold on a second.
Oh, okay, but okay.
Maybe I can jump in. Gabrielle, are you able to, are you able to add teaching points? You can just type anything in the teaching point. And sorry, not Gabby, excuse me. Are you able to type anything in the teaching points?
How about now? Are you able to see it?
No, I can write, but it doesn't
No.
appear. I think you should stop sharing and share again, Travis.
Yeah, there's
maybe.
this weird equal sign in the middle of the screen with like a hyphen through. I'm not sure if that is related.
Yeah, maybe it just froze. I stopped shared and shared.
Yeah.
Are you able to see it now?
All
Now
good.
can we see it?
So white count, the hemoglobin 7.5, is that what we got, Gabrielle?
Yeah,
And white
Right.
count was 16.6.
yeah, right. And platelets, 760,000. Reticulocyte count, 2%. Mean corpuscular volume, 84. INR, 2.3. No, sorry, 1.3. Total bilirubin, 0.6. Liver enzymes, TGO 90, TGP 35. I think TGO is AST and TGP is ALT. Sodium 133. Potassium 3.2. Chloride 105. Glucose 87. Creatinine 1. I hope this is translated. Okay, erythrocyte sedimentation rate. Is that okay? Was 52, was elevated. Albumin 4. The Urion labs were normal. I don't have it, sorry. Occult blood test was positive. Fecal leukocytes were 70 per cam, 70 per cam. They also did microscopy of the fecal sample, searching for strongyloides, but it was negative. They only found Giardia lamblia trophozoites. They also did a double contrast colon X-ray, which I can show you, that showed a proliferative and infiltrative process in the second and ascendant colon. Maybe I can share my screen for a minute. While doing that, they also did a colonoscopy that showed an ileocecal infiltrative and ulcerated lesion and other ulcers in the transverse colon.
And Gabrielle, you wanted to share your screen, is that right?
Yeah.
Can we stop sharing so that Gabrielle can share his screen? And
You
maybe
guys
you can
can see
teach
it?
us, Gabrielle, you can teach us what we're looking at, okay?
Yeah. So I don't have a CT, but this is a double contrast X-ray that show an infiltrative process near the cecum and in the transverse colon also. Here there is like, the contrast is not passing well. So that was the most impressive finding of this image. Colonoscopy, I don't have it, but they saw big ulcer, infiltrative ulcer in the cecum and other ulcers in the transverse colon. And the biopsy will reveal the final diagnosis.
What did you say was the final diagnosis? Just joking. Gabrielle, you have me at the edge of my seat. All right, so I'm gonna do the easy part here and leave the hard part for Robbie. The imaging, I'm gonna leave for Robbie, and then I'll talk about the other data. And oftentimes in cases like this, it does come down to a biopsy. But let's challenge some of our hypotheses that we created in the first couple of portions of this really expert presentation by Gabrielle. Very good job. So let's start with the CBC. Whenever you do a CBC like this, and when you're worried about parasites, you definitely want to know the differential in the white blood cell count. And we're worried about fungi. And Robbie said histoplasmosis, which can lead to histoplasmoma, like a tuberculoma, which is the mass. So I would ask Gabrielle, do you have an eosinophil count on the white blood cell?
No, sorry, I don't have it.
No, don't be sorry. There's no need to be sorry. Sorry, I even proposed it. So then let's go to the platelet count. This is thrombocytosis. And we also have an anemia, which is normocytic, but that does not exclude microcytic etiologies. So one question becomes, is this reactive thrombocytosis from microcytic anemia related to iron deficiency? So in a patient like this, I would be interested in a ferritin to see if the patient is iron deficient. Then we're dealing with an inflammatory process. The question becomes, what types of inflammatory processes can lead to a thrombocytosis? When you think of inflammation, always think about consider thinking about our I-made mnemonic, infection, malignancy, autoimmune. What infectious causes? Not your typical bacteria. This would be in line with a subacute to chronic organism like TB, like histoplasmosis, like atypical bacteria. Whenever I think TB, I always think histo, always. And then the other stuff I think about too is actino and nocardia, but that would not be consistent with this presentation. When you think about cancers, I think we've probably ruled out lymphoma with this thrombocytosis, and we probably ruled out adenocarcinoma with the fever and inflammation. So as much as I want to say, well, could you have a cancer and it's infiltrating? I just don't think of solid cancers causing much of an inflammatory syndrome. So cancer has gone down, lymphoma and solid cancer. Infection is up. Autoimmune, this would be seronegative, not seropositive. That causes, lupus is not possible here. And I just don't like autoimmune for this presentation. My entire focus is infection. And this is when I look at Gabrielle's face to see if he's smiling or not, which would either be an affirmation for this possibility. So we're dealing with, I think, an infection here. And now let's move to the chemistry panel. Any loss of fluid below the pylorus is going to be bicarb rich. If you lose bicarb rich, what's left behind is going to be an acidosis. So diarrhea causes a non-gap metabolic acidosis with a negative urine anion gap. Here I'm going to calculate the gap. Although I don't have the bicarb, I'm going to say this is non-gap, patient's hypokalemic, all consistent with diarrhea. Doesn't help me make much progress. Then we go to the AST and ALT. And here, the question is this liver or extrahepatic? The ratio makes me favor an extrahepatic cause or alcohol. What extrahepatic causes? Stuff that causes muscle turnover, heart cell turnover, anything that leads to tissue turnover. That's what I would make of the AST and ALT ratio, though I can't exclude possibility of something involving the liver as well. What to do with the giardia? If this was isolated diarrhea, I would say treat the giardia and see how the patient does. But this is not just isolated. This is lymphadenopathy and a mass. So maybe I'll pass the mic to Robbie here to see what additional thoughts he has. And I'm always here if he wants to go back and forth.
Tiki-taka, always. You know, isn't it cool how you can look at that platelet count and the fever and the combination and be like, it's not cancer. I just think that's so cool. So thank you for making that point so crystal clear. And I agree. I think the spotlight is on excluding chronic infection. And if we exclude all infections, this is totally compatible with aggressive Crohn's disease in a 36-year-old man. But as Reza emphasized, the momentum should be to exclude infection. So I'm going to tell you that there's no way I want to remember all the infections to include here. So I'm going to share with you my checklist for them. Here we are. They all under on the chronic colitis bucket. The one infection that is prominent, the two prominent infections to consider under chronic colitis that are viral in nature are CMV and HIV. You'll see CMV misdiagnosed as IBD and IBD misdiagnosed as CMV all the time. But what makes CMV less likely is the mass forming propensity. CMV, while it is totally accountable for the ulcerative disease you can see here, it is very unusual to cause a mass. What bacteria, the foodborne bacteria that we've been reflecting on, like Salmonella and Yersinia, are possible, but again, the degree of mass formation here is very, very unusual. There are a couple of spirochetes to think about as causing chronic colitis. We've had Druve stump us with intestinal spirochetosis on VMR before, and syphilis is less compatible with a mass-forming lesion. So within bacteria, the spotlight is on granuloma. Give me one sec, folks. Let me just close the window because I can see it's really loud. One sec. So granuloma. Mycobacteria, very possible, AVM intracellularly and tuberculosis, but less likely because for two reasons. One, there doesn't appear to be a pulmonary focus of infection here, and the patient had TB that was treated. Could this be Mycobacterium bovis? For sure, bovis is usually ingested and causes this. So I would say of all the Mycobacteria, bovis is possible. Actino, very, very possible here. Very possible. What are the things against actino? The thing against actino is most patients don't notice a fever. Actino is a very cold infectious disease, meaning that patients will just really mimic cancer in that they don't typically have a prominent fever. So the fact that he had febrile symptoms makes actino a little bit less likely. Whipple's is an important consideration, but less likely to cause such a prominent mass, and the patient's a little young for Whipple's disease. Lymphogranuloma venereum, an incredible infection to entertain, but probably would not be picked up on histopathology. It's actually nearly impossible to see chlamydia on histopathology, which is why we usually empirically treat for it in the emergency room. Histoplasmosis, can't make a stronger argument. This is a case very compatible with GI histoplasmosis, but what makes it less likely is the lack of any extra intestinal signature. Entamoeba histolytica, a big hit here for sure. A chronic fistula and the anal fissure. Now, what can we use to prioritize one thing over the other? I'm not sure. I really am not. Actino is unlikely to explain the axillary lymphadenopathy that we have here. Mycobacteria certainly would. Whipple's wouldn't. LGV wouldn't. So at the end of the day, I'm not sure what more refining we can do than to study the mass. But I think that the answer probably lies somewhere here on this page, and you take this case and play it 100 times over, you'll probably make contact with each of these in varying frequency. What is it today? I'm not entirely sure, and I'll pass the mic to Reza to see if he has any additional thoughts to add.
Zero additional thoughts. And I love the idea that you brought Crohn's back in the DDX, because you're absolutely right. If this is an abscess, the ulcers, the anal fissure, all can be compatible with inflammatory bowel disease. So I'm very excited for Gabrielle to share with us the final diagnosis.
Yeah, so the biopsy didn't show entamoeba histolytica, no, it wasn't positive for markers for lymphoma, but I have an image of the biopsy. Maybe I could show it to you. So the biopsy showed that, sorry, I don't know. Okay. So it was positive for Paracoccidioides brasiliensis, as Kushal said later in the chat. You can see some yeast like a sheep whale appearance. I think this is the most similar to a sheep whale or Mikey. We say in Spanish, orejas de Mickey. And what I learned from this case is that learning the risk factors. So there were clues in the past medical history and who the patient was. First, he was a male patient, as Kushal made a tweet yesterday that paracoccidioides is most prevalent in males because estrogens have protective effect in the progression of the disease. And also they are more reported in humid tropical areas. Here in Peru, is endemic, in Loreto, San Martin, endemic like climate similar to the Amazon, but most reported cases in the world are from Brazil and Colombia. And also what I learned from this case is that paracoccidioides, if it has a gastrointestinal manifestation, the most common location would be the ileocecal valve and the cecum. It has a predisposed to infect that place. And in the colonoscopy, you would see ulcers, you will see infiltrative lesions similar to Crohn's. It can be a Crohn's mimicker, and it's a amoeba histolytica mimicker too. But the gastrointestinal manifestations are rare. So before thinking in paracoccidioides, you should think in TB, then TB, then TB, because TB has an ileocecal prevalence too. And then you should think of histoplasma and lymphoma first before thinking paracoccidioides, because the manifestations are rare there. So you guys did very well. Sorry, I would like to add that another clue in this case was the axillary lymphadenopathy with suppuration, because if there is any lymph involvement, then if accompanied with gastrointestinal manifestations, paracoccidioides is one probability, taking in consideration the patient was from an endemic area. So that's what I learned from this case, and I hope you guys like it.
Gabrielle, we didn't like it, we loved it. This was a brilliant presentation. And if everyone can at some point, go look at our schema for chronic diarrhea. What you don't see is fungal infection under invasive infections. But look at our schema again in a week and you'll see fungal infections there. And paracoccidiomycosis will be the prototypical example because of Gabrielle's case. Thank you, Gabrielle.
Gabrielle, you were a master, stumped again, learned even more. Thank you so much. I'll pass the mic to Gabriella to summarize the teaching points and take us home.
Thanks to you guys.
Thank you. It was a great case and an amazing discussion. So the teaching points here, so I think the most important are first the approach to chronic diarrhea, that we have to think about inflammatory or non-inflammatory causes. Inflammatory, usually the diarrhea will have hematochezia, blood, pus, and also the patient will have fever. There are a lot of causes of inflammatory and non-inflammatory causes. For the non-inflammatory causes, we have to look for the osmolarity gap, which if it's below 50, it's secretory, and if it's higher than 50, it can be osmotic, fatty, or functional. Also, another thing that it's important to learn from this case was the approach to abdominal pain. And the acute abdominal pain, usually you have to do an abdominal CT scan. Only 5 diseases do not show up in this exam, which are inferior myocardial infarction, pancreatitis, urinary retention, zoster, and hernia. And you have to do a lot of exams to exclude those diseases that do not appear in the abdominal CT, which are AKG, lipase, ultrasound point of care, and the clinical exam to exclude hernia and zoster. Also, this patient had a chronic abdominal pain, and the approach, we have to think about 5 main causes, which are irritable bowel syndrome, endometriosis, acne, which is anterior cutaneous nerve entrapment syndrome, chronic pancreatitis, and chronic mesenteric ischemia. Another pro, it's about the anal fissure that this patient has, and when we put together anal fissure and diarrhea, the first cause is going to be constipation, especially if it's in the posterior midline, But if it's in other localizations that are more atypical, like anterior or lateral, we have to think about systemic causes. And the most important are Crohn's, TB, actinomycosis, and amoeba histolytica. And for me, I think the most exciting part was the differential diagnosis of infectious agents. And I liked the approach that I think Heza taught us about the pairs of infectious agents. So when we think about actinomyces, we also have to think about nocardia. And when we think about TB, we also have to think about histo. So thank you for the case, Gabriel, and for the discussions. And I learned so much with you.
Honestly, I'm thinking of naming, if I ever have kids, one of them Gabrielle or Gabriella, based on the brilliance that's coming through. Anyone named Gab is crushing it. Thank you all so much.
Thank you, guys. Always a pleasure.